I'm Stephen Cassivi. I'm a general thoracic surgeon, a chest surgeon at Mayo Clinic. Hiatal hernia is a condition that occurs when the top of the stomach is protruding or moves into the chest. It can happen with just a small amount of the top of the stomach, or in some more serious cases, a larger part or the entire stomach, with sometimes the intestines, move up into the chest through the passageway in the diaphragm where the stomach and the esophagus usually are passing through. That's what we call the hiatus, and therefore a hernia there is called a hiatal hernia. A hiatal hernia can be a problem because it can cause a number of distressing symptoms, as well as can lead to certain emergencies. The symptoms that patients often complain of are obstruction. In other words, a patient has a difficulty swallowing food. They can feel like food gets caught in their esophagus or in the middle of the chest area. They can also sometimes feel full very quickly after eating, a condition called early satiety. Another problem that can happen is if the stomach is up in the chest, it can sometimes twist. And in twisting, it can occasionally twist off some of the blood supply to the stomach. Thankfully, the stomach is very well supplied with blood, with different routes for blood to get to the stomach. But if it's up in the chest, it can sometimes twist and compromise the blood flow that it needs. And that is evidenced by pain, often pain after eating. And so patients present or come to the doctor because they get this pain that occurs with eating. It resolves over a number of hours, or in some emergency situations it doesn't resolve. And that's a condition that needs to be dealt with urgently and sometimes requires urgent surgery. Other symptoms that patients can present with are fatigue, and that fatigue is related secondarily to anemia, where there's, because of the stomach being up in the chest, patients develop erosions in the lining of the stomach and gradually lose blood and become anemic. It can occur without the patient knowing, or it can be more florid with having bouts of vomiting up blood or having black stools. One other symptom that sometimes occurs is patients have heartburn. With a hiatal hernia, sort of a garden variety hiatal hernia with just a small amount of the stomach protruding into the chest, the valve at the lower part of the esophagus that usually helps to keep food from refluxing or passing back up into the chest is loosened. And the normal structures, normal anatomic structures that keep us from getting reflux can be damaged or loosened, and you get heartburn. That's one of the other symptoms that can occur with hiatal hernia. Generally, this condition is diagnosed by a careful history. A doctor can pick this up with recognizing those symptoms that the patient is bringing to the doctor's attention. Occasionally, however, it's picked up just as a happenstance in an X-ray, a chest X-ray, or a CT scan that's done for another reason. And the doctor will notice that, yes, you have a hiatal hernia. If there are symptoms related to it, it makes sense to have it worked up or looked into more significantly. In terms of diagnosing the symptoms and confirming the diagnosis after a patient comes to the doctor complaining of or bringing those symptoms up, certain tests can be done, including a barium swallow or a contrast swallow, where the patient swallows a certain amount of dye or contrast material that is picked up on an X-ray, and in that we can image the stomach and the esophagus and see whether or not the stomach is up in the chest or protruding into the chest. It can often be seen on a chest x-ray, but the dye helps to really confirm that that's what we're seeing, and confirm and outline the location of the stomach and the esophagus. Another test that can be done is a CT scan, and that will also confirm the presence of the stomach in the chest, or the hiatal hernia. One more confirmatory test is an endoscopy, an upper endoscopy, also called an esophagogastroduodenoscopy. In other words, where the physician or the surgeon will pass a flexible scope down into the esophagus and stomach, and through that they can confirm that the stomach is up in the chest, or that there's a small or a larger hiatal hernia. With that test, they can also look for complications such as inflammation or Barrett's esophagus that can occur in conjunction with this condition. In terms of treatment, patients who have a hiatal hernia and have symptoms from this should seek an opinion on whether something should be done. Depending on the severity of the symptoms and the nature of the symptoms, it may be worthwhile to consider a surgical repair. That's the main way of treating this condition. Surgical repair can be done a number of different ways. And I think one of the advantages we have in our group of thoracic surgeons is the ability to come at this from many different directions. Frequently, we manage this through minimally invasive access through 5 small incisions in the belly, in the abdomen. However, in certain cases, it requires an open approach, or a standard incisional surgery in the abdomen, and occasionally in the chest as well. And I think that's one of the advantages of having a thoracic or chest surgeon managing this problem, because they have all of those arrows in their quiver. They can approach this from many different directions and have those different options. The other advantage is that this is not just a condition of the stomach, but it's a condition of the entire upper gastrointestinal system. And in view of that, I think it is best treated by someone who understands the entire upper gastrointestinal system. A chest surgeon understands, can deal with, has experience dealing with the esophagus, and in fact respects the esophagus, which is an organ that if you don't have to have an operation on, it's better not to. But in conditions where you need an operation, I think it should be done by a chest surgeon who understands and can manage all of the aspects of esophageal surgery. The key thing to remember in hiatal hernia surgery is having someone aware of the potential and being able to deal with a shortened esophagus. In other words, the esophagus, the organ which serves as a passageway and a pathway for food from the back of the throat down to the stomach, if it's shortened, then your repair and bringing the stomach back down into the chest will be under back down into the abdomen will be under tension, and that will lead to potential recurrence or early recurrence of this problem. So recognizing a shortened esophagus is important, and being able to deal with it by lengthening the esophagus by way of a wedge gastroplasty or a colus procedure, which is a form of a gastroplasty. In other words, where the stomach, an incision is made on the stomach to lengthen the esophagus. Those measures are an important aspect of this type of surgery and allow for a tension-free repair so that the risk of recurrence is less. One of the other important aspects to remember is that nowadays we can repair this minimally invasively. Through 5 small incisions in the abdomen, we can bring the stomach down and, if needed, provide an esophageal lengthening procedure that then allows for a tension-free repair, and the patients can usually leave the hospital in 1 or 2 days and return to their usual activities in a quicker fashion than with the conventional open procedures that have been done in the past. That being said, occasionally an open procedure is required, and the nice thing is that our group is comfortable with either approach. In terms of choosing the approach for surgical repair of this condition, everyone should be considered for minimally invasive surgery. There are a few reasons that one patient versus another may not be ultimately a candidate for the minimally invasive approach. But our experience in this has grown to the point where I think it's important from the outset to consider everyone as a potential candidate for the minimally invasive route. And in fact, most people are. Those patients who aren't, we're able to manage through the old conventional open procedure, but that group of patients is growing fewer and fewer.